I was thinking I thought lymphoma tumor board is a very large thing to discuss. So I just thought we would just discuss one aspect of lymphoma in the time provided, which is about 20 to 25 minutes. And so without much ado, I hope all my panelists are there: Dr. Kajal, Shah, Anupama, Vikas, Nadeem, and Dr. Prateek Tiwari, Dilip, Ramrakhiani, and Ashish Gupta.
Hari sir, sorry to interrupt. One prestigious faculty, international faculty, Dr. Ranjana H is also here.
Oh, sir, I'm so sorry. Sorry.
No problem.
Yeah, I'm so sorry, because in my email suddenly I saw her name missing, so I was not sure whether she was there.
She's there.
Yeah, thank you. So nice to hear from you, Ranjana. Yeah. So I would just go ahead with the discussion today. So we just to set the ball rolling, we do understand that diffuse large B-cell lymphoma is the most common disease, peak incidence in the 6th decade. Clinical outcomes and molecular features highly heterogeneous, and large cells with loss of follicular architecture, then both nodal and extranodal manifestations for the disease. And it's about curable in 50%, and the median survival remains about weeks to months if not treated. And we do understand the outcomes. We do expect about 50 to 60% of them to actually be cured with our standard therapy. 20 to 30% do relapse despite going into remission. About 5% go into a partial response, and about 15 to 25% are refractory to any chemotherapy. So we know that for the 60% is unlikely to improve outcomes in this subset with any other kind of treatment. But what we need to identify are these subgroups beforehand to improve outcomes. And we do understand also that from the data from the rituximab era, that the outcomes have dramatically changed, with consistently bringing about in excess of 15% better survival with rituximab, and the limited stage disease, of course, doing a lot better. And we know that, again, the 60% of the patients will be cured of the disease. And we do understand in our bedside, still the IPI index holds good in these patients, but it does not capture the molecular heterogeneity of DLBL, and that's where the challenge lies. And this is an old slide, but we do understand this has not changed much. We do actually still think about activated B-cell lymphomas and the German center lymphomas at a molecular level, and we know that they are distinct entities. So with that, I just go into the scenario one, wherein we have this 47-year-old lady with no comorbidities, and who presents with a swelling involving the right lower aspect of alveolus, and progressively increasing, painless, and oral cavity is normal except for the mild fullness in the gingivobuccal fossa, and no other swelling or lymph nodes that are noted clinically, and systemic evaluation is essentially normal. Wide parameters, CBCs and biochemical parameters are normal. The LDH level is at the upper limit of normal. And the biopsy reveals a high-grade lymphoma, diffuse large B-cell type, and on immunohistochemistry suggests a GCP type by the Hans algorithm. And the PET scan was done as part of the staging at baseline, and this shows a locoregional bulky disease. No bone involvement was noted, and the marrow was done, which was reported as normal. And so we have a stage 1A. I didn't put X because it was not fitting. It was only 6 into 5 centimeter, and we have an RIPI score of 0. So and this was the PET scan which we have of this patient, mainly a large tumor in the involving the right alveolar region. So the questions that I would ask is, what would be the standard recommendation for them? I will ask, and then I would ask our expert to also combine what the opinions are, to give her expert opinion on this. So what would be the standard recommendation? If I may ask if I may ask Anupama to give her comments on what would be your standard recommendation here. Is Anupama there? Hello? Anupama? Is Dr. Anupama there?
Yes, sir, she's there.
Yeah.
Dr. Anupama, can you unmute yourself?
Yeah, so
yes, I think connection is unstable, but I did hear the case. Can you hear me?
Yes, we can hear you right now. Yes, yeah.
Yes, so relatively young lady, 47-year-old with early stage disease, but a bulky lesion. I would, if patient affording, like to go for further testing. Like I would like to do the FISH to see whether this is aggressive kind of lymphoma, like a double hit, triple hit lymphoma, and then plan the therapy accordingly.
Okay. Is there any additional information, as you rightly said, how important is it to actually look in an early stage lymphoma with a standard GCP subtype to actually look in for any additional information, as you remarked over here, to do a FISH analysis? I would put this question to Dr. Ranjana Advani. Say, would you really think about doing a FISH analysis, or is it a practice to look for a double hit in all lymphomas, especially of the GCB type?
So, I mean, at major academic centers in the US, it's we don't do everybody gets a MIC as a starting point.
Yes.
And only if the MIC is positive that you go on to the next thing. In this patient, there is data to say that in early stage large cell lymphoma, which is in early stage aggressive lymphomas, which are MIC double hit, there is no advantage of a more aggressive regimen compared to R-CHOP. So I think if one is resource constrained, you don't have to do it in early stage disease because the outcomes don't matter. However, if it's advanced stage, I think it's really important to do because that's where you would not necessarily use R-CHOP. I have a question. When I looked at your PET scan, the tumor in the mandible seemed to be crossing the lower mandible, and I'm not sure, this may be external involvement too. It's not pure research. The staging wise, while it's stage 1A, probably 1AE, there is some data to suggest that external involvement can play a factor in this, and that would sort of sway me a little bit later. You'll ask that question afterwards, but it purely stage 1 disease, if you're resource constrained and doing a MIC is not part of your panel, this is the one scenario where you might get away with it.
Yeah, so I had an opportunity to evaluate this patient, and it was it was a fairly large tumor involving the entire submandibular region, it was difficult to say whether it was, but clinically it looked more like a nodal disease, yes, and there was nothing within the oral cavity to suggest that there was any soft tissue component within. It was mainly outside in the submandibular region. But your point is well taken that yes, the PET scan, because this was a limited scan which I could just project. So there is, you're right in that there could have been an extranodal component to this. So we do understand that the gene expression profiling, we know that GCB and ABC demonstrate distinctly different oncogenic programs, and the ABC is characterized by a chronic active signaling of the BCR pathway and activation of the nuclear factor kappa B pathway. And we do also know that GCB tumor exhibits increased genomic instability. We also know that some of the recurrent mutations seen in DLBs are distinctive based on the cell of origin, and some have clear prognostic significance, and others likely to influence a response or non-response to specific therapies. So the next question that we have is that given that it is a limited stage, what would be our strategy? I mean, Dr. Ranjana has already alluded to the fact that irrespective of what we might just go in for standard chemoimmunotherapy, even if we do not know that because it's a limited stage, it looks like a limited stage disease. And so I would just ask Dr. Vikas, would you like to comment upon, would you think about abbreviating cycles of chemotherapy over here? And what is the dosing that you would look at in this patient?
So yes, sir. So limited stage disease where IPI is 0. So patient belong to low risk category. So we can abbreviate the cycles to 4, like the 4 cycles, and the dosing will remain the same, the standard R-CHOP. Dosing I will not be reducing.
So I mean, you would not reduce dose, but you will abbreviate. And if so, how many cycles would you think as being safe over here in these patients? That is something that has always been deliberated in these situations.
Around 4 cycles, sir, as compared to 6. 4 also we can deliver.
Okay, so I would ask the next question to Prateek Tiwari. I mean, would you incorporate radiotherapy into the treatment schema for this patient? Is Dr. Prateek? Is he on, Dr. Prateek? If not, I will request Dr. Kajal. Hello.
Yeah, we consider radiotherapy to if patient have because of patient have bulky disease and localized disease, so we consolidate with the radiation.
And how many cycles, in your opinion, would be sufficient in terms of supporting it with radiotherapy?
Generally, we give 4 cycle of R-CHOP and we evaluate with PET-CT scan and check the response. If disease in complete remission, we consolidate with the radiation.
Dr. Ranjana, your views on this, because there's always such a lot of debate on how many cycles has to be given in these patients, and what is the consensus that we have in this situation?
So I think you can extrapolate from 3 recent trials which have been presented or published. The German trial, which looked at 4 cycles, and then that was really not PET adapted, but those patients got 4 cycles and they got 2 additional cycles of Rituxan, and then they got a radiotherapy. And the SWOG trial, which was presented at ASH last year, where they got just 4 of R-CHOP, and if they were PET negative, they got nothing else. And then the British Columbia retrospective data, where patients got 4 cycles of chemotherapy, and if they were PET negative, they did not get anything. And that's only non-bulky disease. This patient is not being treated on any trial. So I wouldn't go in with any pre-fixed ideas. I'd see how the patient responds clinically. So again, depending on whether you are able to do a PET or not, I would definitely try to do a PET. I mean, she has such a big palpable mass that you're going to be able to see clinically whether she's responding or not. Mm-hmm. And if after 3 to 4 cycles she's responded nicely, do a PET. And if it's PET negative, if there's no, that's why I was bringing up the point of bony involvement. If there's no extranodal involvement of bone over there, there's enough data to say that you don't really need more therapy after that. You could just call it a day after 4 cycles. If, however, the response is incomplete, or you're not able to do a PET to confirm that it is truly a CR and you only have a CT available, which will probably still show some mass, or you have bony involvement, I would add radiotherapy.
So yes, so that's one of the important things that even the PET or the CT scan, if there is bony involvement, that is something that you would always, irrespective of what whatever the responses, we would be inclined towards giving radiotherapy in these situations. Is that right, Dr. Advani? I mean, in all involvement of the bone, we would consider giving radiotherapy. That's what we need.
Yes, by and large, yes.
Yes. Okay, thank you. So we do, I mean, as Dr. Advani did allude to, we have 3 rituximab-era studies for early stage diffuse large B-cell lymphoma. The phase 2, as she alluded to, the British Columbia study, which looked at 308 patients, 3 cycles of CHOP followed by Asati. The PFS and overall survival was 80 to 81% at 5 years, 63 to 74% at 10 years for these patients. And the SWOG study also, which was again the pre-rituximab era, showed a better progression-free survival for patients when they received 3 cycles of CHOP plus IFRT versus 3 cycles of CHOP. But the problem of the SWOG, the updated analysis of 10 years of follow-up showed an increased frequency of late recurrences and an absence of plateau in the survival curve. And we know that in the more in the rituximab era, if you look at the subset analysis of the MINT study, the addition of involved field radiotherapy as a consolidation following chemoimmunotherapy did not improve clinical endpoints in these patients, but that was a subset analysis. But the SWOG analysis, SWOG phase 2 study did talk about, it was a small study, 60 patients with limited stage diffuse large B-cell lymphoma. The PFS and overall survival were 88 and 92% respectively, and considered superior to the historical controls. There have been other studies from the French group, they were using ACVBP regimen also, where they have suggested that using radiotherapy may not add too much to these to the treatment protocol. But then the debate still lies, and as we have to take it on an individual basis. So this is the FLIER study, which looked at, but I must confess that this was for non-bulky disease. This patient has bordering around the bulky disease. And this was a study which looked at giving 4 cycles of R-CHOP plus and randomizing them to 6 versus 4 cycles plus 2 additional cycles of rituximab. And you will notice that the outcomes are equivalent in terms of, and thereafter, so in non-bulky disease early stage, we may resort to just 4 cycles with 2 additional doses of rituximab. This was a well-conducted randomized study with well-balanced patient numbers over here. As Dr. Advani also alluded to, the use of PET scans, and I can ask any of our, can I request Ashish Gupta as to how often do you use PET scans to determine the, consider using radiotherapy in these patients? Is Dr. Ashish Gupta available?
No, sir. He might be having internet issue, so he'll try to join in another few seconds. Sir.
Can I ask Anupama to take this question? Yes. Is Dr. Anupama there?
Yes. So in my center,
we can't hear you. I think she has an internet. For the interest of time, I would just go. But this was not for early stage disease, but just to extrapolate that for all those patients who were PET positive, following giving involved field radiotherapy to limited stage, did improve outcomes and bring about almost equivalent results. And this was the same point which Dr. Advani alluded to. So the second case, so this patient was treated with 3 cycles of chemotherapy, and she did achieve a complete response. And we did, because of the proximity to the bone, and also the fact that there might be a soft tissue component to the whole thing, we did go ahead with radiation to the patient, and she's doing well today. So the second patient is again a young lady, noticed a swelling involving her left axilla, which was recent of about 3 weeks duration, and she consulted with her physician to have a breast, and the physician noted that she also had a breast lump, which was about 5 to 6 centimeters, and the right axillary node, which is about 4 to 3 centimeters, and was thought to be breast cancer. And she was evaluated and underwent a true-cut biopsy, and it came back as a high-grade diffuse large B-cell lymphoma. And the PET scan did show the extranodal disease in the breast, with a bulky ipsilateral axillary node, and there was no other activity anywhere. We did do a bone marrow for her, and the bone marrow was negative. The LDH was high at 460, and the CBC biochemical parameters essentially normal. She had on immunohistochemistry, c-MYC was 60%, BCL2 was reported as about 40%, and BCL6 was also positive over here. And because of this c-MYC positivity, and also the fact that the GCB subtype was seen on immunohistochemistry according to the Hans algorithm, we also ran a FISH analysis on this patient. It came back as a double hit lymphoma. So here we have an early stage patient with a double hit lymphoma. So again, it comes to, we have already addressed this question in the previous previous case study as to when we would address FISH analysis. So in the interest of time, I'll just go ahead and say that we'll just go ahead to the treatment options for this patient. Would it be different? So I would ask, can I have Dr. Dilip is online? Can
yes, yes, yes.
Dr. Dilip, yes, yeah, thanks.
So I think whenever there is IHC overexpression of MYC, we always run FISH on all three, MYC, BCL2 and BCL6.
Yeah.
So as this was alluded to by Dr. Ranjana Advani also, so that is the protocol to be followed.
Yes. Okay. Yeah. So what about the treatment options for these patients? Is it going to be different?
So I'm basically a pathologist. Yeah, I'm a pathologist, so I can only comment on the pathology.
I'm sorry, Dr. Dilip. I'm sorry about that. So I would ask.
May I just clarify one thing?
Yes,
I think what I said about testing was we check for FISH translocation, the BCL2, BCL6 only if the MYC is translocated.
Yeah. Okay.
Not based on immunohistochemistry expression.
Okay. That is point well taken, Dr. Advani. Yeah. So, so that is what we also do. But in the interest, I just put it that BCL because we saw the CMYC expression, overexpression. We went ahead and did the BCL2 and BCL6 also in this patient. So, Dr. Vikas, what about the treatment options for this patient in your clinical practice? How would you approach this patient? Would you treat it differently?
Yes, sir. So breast DLBCL is an aggressive malignancy. It's not the usual DLBCL. They behave very poorly, and as
we have a double hit also here. We have a double hit.
Double hit is also there. So R-CHOP may not be the sufficient treatment. At present, we don't know what is the optimal treatment, but definitely we know that R-CHOP may not be sufficient. So we are more using the RDA-EPOCH or hypersiever-like therapy. So, and most of the time I end up using RDA-EPOCH in these patients.
So, Dr. Advani, you have already discussed that because it's an early stage disease, you could use R-CHOP over here as a standard regimen. Would you still consider the same for this patient because she does have a breast component to that, a large extranodal disease also over here?
So, I mean, as just stated, DLBCL involving the breasts, even if it did not have the triple or double hit, do worse compared to garden variety DLBCL, and typically fail in the CNS. So whatever you do, the CNS prophylaxis has to be incorporated. As far as choice of regimen, I don't think any of the retrospective series looking at early stage broke it down to the granularity of what extranodal sites were involved. And if you think the patient is young and can tolerate more intensive therapy, in this particular scenario, I would probably favor using a more aggressive approach than R-CHOP. But there is no big randomized data which I can do to support that. But if this patient is a little older or cannot tolerate the dose escalations which you have to do, then think R-CHOP is also okay, but this is somebody I would also radiate and give CNS prophylaxis.
Sure. So that comes to the point of CNS prophylaxis, doctor. So what kind? Is it high-dose methotrexate? And what would be the sequencing of this kind of CNS prophylaxis if you want to use it? Yeah.
So it's to decide what kind of prophylaxis, you need to sort of look at the patterns of failure. Is the failure going to be leptomeningeal or is the failure going to be parenchymal? Yeah. So when you have testicular involvement or breast involvement, the failure tends to be parenchymal, not necessarily leptomeningeal. So giving if in a young patient, giving intrathecal is probably too little. I mean, it's okay if you have an older patient and you don't have a choice. So in somebody who's 30, in the mid 30s, I think high-dose methotrexate defined as about 2.5 to 3.5 grams would be required. As for the timing of it, if you're using dose-adjusted EPOCH, it's hard to sort of do that with dose-adjusted EPOCH. What we typically land up doing then is changing the interval of the dose-adjusted EPOCH to a 4-week cycle and then doing it at day 15.
Yeah.
So instead of keeping the dose adjusted epoch as day 1, day 21, we do it day 1, day 28, and then in the middle do methotrexate. An alternative way to do it is, I don't think I would necessarily give this lady 6 cycles of dose adjusted epoch. I think we would just use 4 because it is early stage, and assuming she's PET negative, is coming with the methotrexate after you are done with all your epoch. That's another way to do it. If the patient's much older and you don't have a choice, then you can just do intrathecal. But the pattern of failure is usually parenchymal. So if you can get away with high-dose methotrexate, that would be the more preferred approach.
So I would just ask you to just complete that with the decision for radiation. Is it because it's a double hit? Is it because it's an extranodal site? Or is it because it's a bulky disease over here?
It's all of the above.
Okay. Okay.
All of the above.
Yeah.
So it's a one, we know this is breast lymphomas are more aggressive. So you kind of want to do everything you can. Your best chance to cure a patient is your first chance.
Yeah.
So that's 1. 2, it is bulky. Yeah. And 3, it is extranodal involvement. So given all 3 of those and a histology which is not very favorable, and this is not somebody who's, under 30 where you're worried about developing breast cancer 30 years later. She's like 30, 38 or something.
Right.
I think I would do everything.
So, I'll just run through because I know I'm already 2 minutes beyond schedule, and these are just the theoretical part of diffuse double hit lymphoma. And as Dr. Advani rightly spoke about, the infusion protocol seems to be getting a better CR rate in these patients in terms of this graph that is, these histograms that is seen. And the CNS prophylaxis we have already alluded to, because we do understand that methotrexate regimen, because we do understand that diffuse almost a 12% higher chance of developing CNS parenchymal metastasis in these patients. And the choice of therapy is variable, especially in in early stage diffuse large B-cell liver double hit type. And this was a paper from Tumati group, the patterns of failure, where consolidative radiotherapy improved progression-free survival in 32 double hit lymphomas who had achieved a complete response. And there is a superior 3-year relapse-free survival for such patients. So just to conclude, I would just say that this patient received actually 6 cycles of dose. She tolerated the treatment very well. So we went ahead and gave her the 6 cycles. She achieved CMR on interim PET scan evaluation. She received 3 cycles of high-dose methotrexate, but in her case, we gave it post-conclusion of the 6 cycles of dose-adjusted epoch. And we also concluded that with involved field radiotherapy to the breast. And now it is 18 months and she's on follow-up and she's keeping well. So with that, I will conclude, and thank you to all my panelists. I'm sorry if I've not been able to include some of them enough. My apologies, and thank you for your participation. Thank you. And